Okay. So welcome again, 75 people. Geez, more from India, Sydney, Melbourne. I hope everyone's doing okay with lockdowns and things like that, and you're finding ways to obviously take care of yourself, because that is hard stuff to deal with. Graham, what's your situation right now?
We're pretty free to move about, just got to wear masks, and there's a little thing going on in Logan, not far from where I am. So there's 1,000 odd families who are confined to their houses. That was as of last night, but this is the way it is. We've got away fairly well with things compared to Victoria and New South Wales.
Yeah, it's been same as South Australia. We've been okay. Got Winnie from Taiwan. That's amazing. Welcome. People in Brisbane. People are still piling in, so I'm going to give it a second to continue letting them all in as well. And Graham, you can do that too. I was just wondering, I know with 85 people in the room, the chat room can, for some people, can be distracting. I am so ADD, I love it. It keeps me on my toes. So if you do want to write maybe what kind of motivated you to come in and join this this chat, of course, it being free is wonderful. But if there's something that motivated you, or if this topic means something to you, I'd love to see in the chat box something about that. And we'll save some time at the end to have some conversation where people can unmute and talk, answer, so we can ask some questions and go back and forth, things like that. Besides that, Graham, you ready to get started?
Yeah, absolutely.
Fantastic. I'm just going to make sure there's nothing important. So Tony says about being creative with addressing complex trauma, of course. So I'd like to start with an acknowledgement of country and acknowledging the traditional owners on the lands of which many of us call in from. I'm in Kaurna country in Adelaide, which is spelled Kaurna. And I'd like to also, Graham, which country are you calling in from?
Yugambeh, so south side of Brisbane, northern end of the Bundjalung Nation.
Wonderful. And I know there's people all over and people from international folks as well joining us. And I'd like to invite you to just for a moment, take a peek out your window and just think about, if you're on unceded lands, what that would have looked like, what that land could have looked like pre-colonial times and the people that lived here. A lot of places, I stole a bunch of pictures from Graham's Youth Flourish Outdoors Facebook group. And one of the things I'm always reminded of is where we take the people that we work with when we go outside. There could be such rich history there that if we take the time to really pay attention to it and acknowledge those First Nations people, the land and the history and the stories really come to life. So if you'd like to, in the chat box, say which country you're calling in from. As I said, I am in Kaurna country. That would be fantastic. We have Rajari, wonderful as well. So Graham and I are good friends and total goofballs as well. You can see Graham is pointing to something very important here. And this is a picture of me when I was in Alaska, working for Alaska Crossings, being a goofball in Alaska as well. Graham, do you want to take a moment to introduce yourself?
Sure, thanks, Will. I'm happy to see that on screen there's a number of people I know already, but there's also a lot of new friends. So I am, oh goodness, what do you describe me as? So I consider myself an adventure-based youth worker. I'm not clinically trained. I don't do the talk therapy thing, and I'm not qualified to do so. I was introduced by somebody who's in the meeting today to the concept of complex trauma back in about 2005, 2006, something like that. because I was trying to figure out why we do the things that we do and why they sometimes work and sometimes they seem to be spectacularly inappropriate for the young people who are presenting for help. And they said, have a look through the lens of complex trauma. So I've been doing that for the last 15 years or more. And I'm just in the last few weeks, there's still things I go, oh, I hadn't thought of that. So it's a really interesting journey to go on when you're riding the wave of a new way of looking at things, because there's so much more information turning up all the time. So when I introduce myself a little bit hard, Will, because I feel quite uninformed about some things that other people seem to know an awful lot about. And now we're going to present on complex trauma and adventure therapy. So, what do I know in the end?
Yes, exactly. Graham and I are good friends that agree on a lot of things and disagree on other things. So when there's a bottle of wine involved, it usually creates a very good debate. Pretty opinionated guys. But my name's Will Dobud, for those that don't know me, and I am a social worker. So I do have some clinical training, which Graham and I also argue about the cash value of that training as well. And so my interest is not only advocating for our field, but really thinking about what can we actually do to become more effective at this work. That's really the most important thing I care about, and what I think about is being better, getting more effective, getting better outcomes for those that seek our service. And I'm located in South Australia, though I am from the United States. One of the things Graham put me onto is the Blue Note Foundation's guidelines for complex trauma and the treatment of complex trauma. I knew trauma was clearly important. I got that in my social work training, but then I also saw a lot of what would be kind of trauma uninformed practice, even though I've never met someone to say they're a trauma uninformed worker. I could see things that not only could harm young people, but in our field, but things that just were very contradictory to where we are, just things we could do. Last year, a group of researchers, some in Australia, some in the UK, reached out to myself, Nevin Harper, Professor Nevin Harper from University of Victoria in Canada, and they reached out to us and said, would you be interested in writing a chapter about wilderness therapy for our book, Nature and Health? And I thought, physical activity, I don't really spend a lot of time thinking about the physical benefits of wilderness therapy and the work we do. But I thought, you know what? Let's go from the trauma lens and think about the brain and neurobiology and the physical benefits that could happen from going outside. And so I knew the person to do this and to bring this in to help guide the ship would be Graham, because Graham's program, Youth Flourish Outdoors, in my view, is really the standard of really taking the literature, taking complex trauma guidelines, and implementing them into the work that he does. And I hope that we have time to learn a bit about that as well. And everyone who registered, I will send you that chapter we wrote in that book as well. So trauma has a very long, right? We often think that PTSD with soldiers, right? Veterans coming back from war. We used to call it combat fatigue. Then it was shell shock. Then we have war neurosis. But one of the issues, and I think Graham will touch on this in a second, is we were seeing similar symptoms in young people who were removed from their homes, young people in foster care. Is that right, Graham?
Yeah, and if you read Bessel van der Kolk's work, that's where he is basically responsible for the PTSD diagnosis being created. He and people he was working with in the VA, as they call it, and he with these people worked this out, that this is the current way we look at shell shock. But then he would occasionally have a young person come through his treatment room and say, well, hang on, this person's presenting very much like these soldiers. So there's got to be something similar in their history with that. So the PTSD thing is good in that way, but it's also misleading. I think Bessel is on record of saying that he kind of is a bit wished he hadn't come up with the PTSD thing, because I think it sent us down a bit of a parallel path to where the complex trauma literature is taking us.
Yeah. And one of the issues is we often think of trauma as an experience. So we think of, and Graham is much better at defining this as well, but when we think of trauma as experience, traumatic experiences are typically defined by their suddenness, the lack of control that a person feels, and then also having some negative emotional attachment to it. Complex trauma is different, Graham, isn't it?
Yeah, and if I can, while I'm doing the talking, I'll leave you with the
That's great.
people who are joining. So people mistake, I think, a genuine mistake. They're mistaking the word complex for an order of magnitude, and that's not the way I see it. But the literature is not at all unified about this. So this is the world according to Graham. My view of complex trauma is that the complexity is that lots of different things are interrelated here. That it's about harm that happened in development and in developmentally important periods. So early childhood's obviously one, late childhood, the puberty thing. There's certain times where I think the adverse experiences are more likely to be harmful than in others, just generally speaking. But because it's mixed up with your development, there's whole range of things physiologically in terms of your understanding of how the world works, your ability to form and maintain relationships is all mixed into this complexity. So for me, complex trauma is not childhood sexual assault, which, trauma warning, we're going to be talking about this sort of stuff. It's not just that. That is certainly adverse and is going to have significant developmental impact. But a lot of complex trauma is the things that we see that seem to have no specific event attached to them. It's just that grinding experience of perhaps living in a place where race is an issue, and you're of the type that gets the minority. Or it could be in a family that is really, really highly functioning, but very, very intolerant of people doing things that are different to the family norm. That can raise all sorts of complex issues, and it's not necessarily an abusive situation. So it's kind of that neglect thing, I think, is a big item here, and the literature constantly gets dragged into this. It's got to be a large event that's caused it, described as you've got on the screen, and I don't think that's what we're dealing with at all. I think that describes PTSD, but complex trauma, I think, is markedly different to what happens after those big events.
Yeah, absolutely. And we know, I think, where my sort of critique of trauma-informed approaches, they're very popular, right? I sat in a workshop a few months ago, and an academic was saying how important it is that we all be trauma-informed. And someone asked, well, how has your organization changed since learning all of this kind of new literature that's coming out? And they said, no, reading the literature just reinforced what we've always done. And I went, so it did nothing. It led to no changes at all. So we really, for those practitioners interested in this topic, we're really interested in inviting you to really consider, based on some of the material that we give you, what this will lead, how this stuff could change what you do, what the actual cash value of being trauma-informed really means. Because we have a sort of big problem in our field of mental health and behavioral health care, that despite creating and constructing new mental illness diagnosis, we now have over 700 to 1,000 different empirically supported treatments to so-called treat those mental illnesses. We don't have 1% of improvement in mental health outcomes for therapeutic and behavioral health care services in about 50 years, over 50 years. So in one way, sometimes we're looking at the wrong stuff. And so we really would encourage you as we go through this to really think about what's going on in this work and how can we make changes that can help us to better treat those we serve. Simply tacking on trauma-informed or trauma-focused to your treatment probably won't make it any better or safer or more ethical, unfortunately. And so we've seen this with trauma-focused CBT is no different, no better in outcomes than its next counterpart as well. So really, the approach that we're going to discuss is really centered on this bottom-up approach. This is often attributed to Dr. Bruce Perry's work as well. So Graham, do you want to give the run through of that?
I'll try, but yeah, neuro is not necessarily the thing that I'm not sure that I'm good at anything much, to be honest. So I think this is a good picture to describe an idea. The detail of it, I won't get into. I think other people could do a better job. But what I like about this picture is its opposite as well, which I'll get to in a sec. So the bottom-up approach means that we're dealing with the back of brain, so way back here. Yep, my hand is on screen, that's good. So the top of your spinal column, effectively, how the brain, that brain in our head interacts with the body. And also we've got a lot of neural tissues distributed across our body. So down to our fingertips in our gut, there's brain material scattered through the body. Comes up through the spinal column and hits the top of your head or the back of your head. So if we're dysregulate, if we're trying to cope with what's going on in the world, that part of the body is always switched on. And in terms of a trauma response, it's going to be either propelling us towards safety seeking, or it's going to be the rest and digest thing that they talk about, where we're just moving about the countryside and we're not alarmed or anything. So that obviously needs to be addressed really early, because otherwise you're not going to be able to access the next level up. And skipping the yellow bit, because I just put the red and the yellow on the screen, I'd lump them together. The limbic system, the middle bit, in the triune brain model, it's called the mammalian brain. That's where relationships, mood, memory, learning, emotion, all those things are in that green area there, which is just diffused throughout the whole brain. It's not a central region at all. So again, that picture doesn't necessarily show that all parts of the brain are going to have some sort of impact on the limbic system. And the top, we've got the cortex, which is where the talk therapies work, because in the cortex, we've got areas like Broca's area and Wernicke's, and these are the places where language is either formed and articulated, or where it's heard and interpreted to have meaning. And if that's in the top part, but we're actually running around dysregulated in the red bit down the bottom, then that means that the top part's not going to be functioning very well. In fact, it's largely going to be switched off for good survival reasons. And talk becomes a very restricted option. So if we've got a person in a treatment room and they are calm and everything, and they're surrounded by safety, then they may be able to talk to things. Perhaps, I don't know, I don't do that work. But if we've got young people who are often still living either in a situation of adversity, or they're not so far removed from it that they can separate how it feels and those memories, we'll talk about different types of memory later, then they're going to be dysregulated further down in this model here, and they're not going to be very articulate linguistically. So bottom-up approaches enable top-down approaches, which then help us to understand the body more, enabling more bottom-up. And so these two things go well together. But most of the talk therapies are housed in that top-down place. And for young people, that's a pretty difficult place to get to. The other thing I'd like you to think about, most people, everyone should know Maslow's hierarchy of needs. And if you think about that, it's the opposite to this triangle that we've got on the screen. I'm pointing at a screen, you can't even see my hand. So Maslow's hierarchy is the opposite. We do a lot of work at that basic human needs level, which is oriented around satisfying the needs of the back of the brainstem and the diencephalon, cerebellum. We're doing a lot of our work there to help those two areas regulate. And we don't have to do so much to make our relationships work. And then we've got to do even less to have this enormous capacity of the cortex doing what it needs. So the two triangles overlaid, I think, give a nice picture of what we're trying to do when I'm doing adventure-based youth work.
Yeah, and I think one of the things what this changed in my programming was I work with, teenagers aren't super stoked about going to see a social worker at the best of times. And most of my experience in wilderness therapy was we really moved really fast. We didn't worry about if somebody was regulated. We wanted them to do a journal assignment or to talk in group therapy and unpack what's going on in their lives. And I think a lot of the ways that I was trained, we were neglecting that the first thing we really have to do is help someone feel safe. Because a lot of times being out, even though we might say things like being outside is really good for your well-being, it's not if you're scared, cold, wet, sunburnt, homesick, all of these feelings that can leave somebody unregulated as well.
And so you're not alone. You're not alone in wilderness therapy there, Will, either. When I first started in outdoor education, then moved into adventure therapy, it was very much of a thing of get them into the bush, away from all this modern living as quickly as you can, because it's the modern living that's the problem. But we didn't think much about the transition and how that helped the young person to be regulated and ready to engage with the experience. It was just like get them out and just shove them into the bush as quickly as possible. And that was not wilderness therapy. That was just what we were doing here.
Yeah.
But I think your next slide is about wilderness therapy. So launch into Daniel.
Yeah. So I know my good friend, Chris Russo is also here. Daniel's driving. I tried to rope him in to be able to say this, but I think we can get stuck in a name game of what is or is not a certain therapy, and then we create turf battles. But I really love Daniel's, Daniel tries to clear this up so it's not too complicated for us all. Every therapy can be nature-based or office-based. Outdoor therapy is not always nature-based. Nature-based therapy is not always outdoors. Adventure therapy is often outside, but is often inside. Wilderness therapy is always outdoors. Wilderness therapy is usually a form of adventure therapy, but not always. Sometimes wilderness therapy is just nature-based therapy. Sometimes it is also adventure therapy. However, when wilderness therapy is adventure therapy, that adventure therapy will be done outdoors. Also, all of those therapies can be either counseling, psychiatry, social work, marriage and family therapy, youth work, education, recreational therapy, or play therapy. So I hope I cleared that up, what wilderness therapy is. I'm joking entirely. What Graham and I hope to talk about is really looking at sort of an expedition model, thinking about having young people and going on some sort of extended stay program. One of the interesting things when I moved to Australia, we did use the term wilderness therapy. That's not always culturally appropriate, and especially because viewing the outdoor environments that we go to as a wilderness, which in the dictionary means uninhabited land, doesn't acknowledge the traditional owners and custodians of those lands. So while we use the term wilderness therapy, we do so cautiously as well. But that said, yeah, and Anita asked good point. And so, yeah, definitely looking at what we really wanted to do with the article that we wrote was looking at wilderness therapy to create a dialogue, sort of in contrast to some of the more negative versions of our practice as well, which we have on this sort of on this slide, in this slide. One of the things, wilderness therapy is really diverse, and so whenever we say wilderness therapy should look one way, the way that I work is going to look drastically different from the way Graham works. It doesn't really lend itself to manualization, but also sometimes what we might view as an unethical version of wilderness therapy practice still gets labeled the same. So if I talk about what my program does under that umbrella term, and then what someone else does is horribly unethical under the same term, we're talking about the, we all get lumped in together. So it's really important as a call to action, I guess, that we take it really personally what other people do in the outdoor therapies as well. And that can be a stain on all of our reputations when we want to advocate for a field, and then the negative side of this gains the most international attention in our work. But one of the things we think about when we link this idea of complex trauma is a reconnecting of human rights. What can seem okay in one program might be a violation of human rights in another context. So we really encourage people to go back to those guidelines, to go back to human rights for people seeking medical treatment or mental health treatment as well. Anything to add to that, Graham?
Yeah, look, I'll step back to the wilderness thing. I think it's important. I think even inside the field of working outdoors for people's health, that there's a lot of disagreement or people talking at cross purposes. So I think definitions are really tricky for us. Then we think about if we're talking to an audience that is people outside of this field, that's even harder, because if we don't know what we're talking about, how do they know? So the wilderness therapy thing is being promoted, particularly out of the States, as a branded therapy with fairly specific things that happen in there. And some of those things are up for debate in a wider conversation. So this chapter was about talking to an international audience who will understand a particular term, and then pulling that term apart a little bit and reconstructing it with a trauma-focused lens or trauma lens, so that it can be more universally used, and we can also deal with some of the things that are concerning people about what that brand name brings with it. So to me, the complex trauma lens helps us to think about what are the first principles of how we engage with people that helps them. And that's where, only recently, like this year, I've started looking at human rights-based adventure therapy to get around some of the very different perspectives people have got on what makes something right and valid. And so I've gone right back to the World Health Organization and the UN to look at what are the international definitions of human rights, what are the expectations on nation states, but also on providers of services. How do we comply, and how do we provide something that's a human rights-based approach to what we do? And I believe the complex trauma literature, if you're looking at it the way I do, that it helps us to understand how we can do that and not infringe somebody's human rights. So that probably gets us to this next slide here. I like this, Will. You've actually got on the left there, you've got one of the Blue Knots guidelines that I haven't actually read. And a little plug for them, they've got, you can get their guidelines for free. They're an Australian organisation, but they have effectively trolled the world literature and a lot of clinical literature as well, to provide a whole range of guidelines and how to work with complex trauma in different ways. And that includes, there's a guideline there for lawyers who are going to be representing young or people who have had a history of abuses and they're in court. So how does the lawyer work in that space? So it's really interesting. They've got not just one set of guidelines, but they've looked at lots of different audiences and how they can work on them. And this is yet another one. I think they must be up to 7 or more different types of guidelines. So if you want them, go Blue Knot guidelines. You'll get in there and you can get the whole lot for free as PDFs.
Yeah, fantastic. And so, yeah, what we did with that chapter that we wrote was look at what do these guidelines, what can they add to our work? So one of the things we started with is these domains that they talk about. And really the most important one is safety. What we don't see in here is really unpacking the trauma and big psychoanalytic sessions of trying to conceptualize what's wrong with the person. We're really looking at creating an experience with safety, trustworthiness, client choice, collaboration, and empowerment. And so in this sort of the way we look at this is it's not us versus them, you know, it's not us and then the naughty kids. It's really how can we create a group that has with the ability to create the least amount, you know, there's an inherent power difference, not only between adult and child, but you know, the helper and the helped. And so we really want to acknowledge that's there and do the best we can to create as equitable of an experience as possible. Of course, when we're outside, we have responsibility for physical safety, but we're also giving our young people as often as possible the opportunity to make choices about when to take a break while hiking, what the schedule for a day, all of these different things. Graham, do you want to add anything?
Yeah, just acknowledge the source there. That's Fallett and Harris came up with that, and they're quite well known in the complex trauma community, these 5 principles. And I think that they're pretty good. They adhere to a human rights-based approach, giving it some detail around the mental health field in particular, but that could probably be used in other contexts as well, I would suspect.
Yeah, so throughout an entire expedition, I know with our team, these things are written in our field manual that we are constantly going back to remind ourselves, do these people feel safe? I mean, for a lot of young people, especially those that come on our program, this could be the longest time that they're away from home. They could feel scared of the dark. They could have had really poor relationships with similar adults to us, and then they might not trust us, or they might not feel that collaboration or that sense of empowerment that's so important. So these core domains really stick with us throughout any program we're doing, whether it's indoors or out. And then we look at this phased approach, and this is where I will pass over to Graham as well, because he is the phased approach guru.
Well, thanks for that truck that you threw me under. So what I did in reviewing the literature and looking at our practice in adventure therapy, however you want to brand it, the phased approach is the clinical complex trauma approach. It's quite universal. There's been meta-analyses done on it, and this works. But theirs is slightly different. So from the talk approach, is slightly different. Now, it would be phase 1 safety, no change. Phase 2 is processing of experience. But I'm a youth worker. I'm not going to process the potentially criminal experience of someone's, you know, where they've been criminally harmed in their early childhood. I'm not qualified to do that. That's not my job. It would be silly and unsafe for me to do that. So I was trying to figure out what can we do, given that there's a lot of people who work in the outdoors and not necessarily clinically trained. And in interviews just that I was reviewing this morning, someone was saying, but also if we're going to be looking at that stuff that happened in the past, we're actually taking them away from the experience because they're no longer present here. They're actually present back in the past. So why would you put on this fantastic experience if you're going to take them away from them and put them back in their history? So, so I think there's something in that about being in this wonderful experience we've got and living and reveling what it's like to not be beset by problem all the time. So the processing of new and positive experiences, I think a lot of people can do this if they're going to focus on just providing the best opportunity for a person that they possibly can. That's a pretty good guide. So slightly different to the clinical literature. Phase 3 in the clinical literature is integration. Now, integration, what they're meaning is integration of dissociated parts into a more singular, unitary sense of self. Again, I'm not talk therapist. It's not my job to go in there and try and do that. And there's lots of arguments in the dissociative communities about whether that's actually a legitimate objective anyway. So the way I see integration, it's how do we get this wonderful experience that we've created together, and how do we help that have some meaning for a person in their future and how they deal with life for the rest of life. So what I noticed on programs is that with generally a lot of programs, and particularly in the wilderness therapy kind of models, you're on this long lived experience. And at the end of it, they get on a bus or in vehicles and they disappear into the sunset, and you wave them goodbye and hope that somehow it's going to help them in the future. I felt really strong feelings about the work that we'd done together and how much that was likely to be pursued when they get away back into their more normal environments. And there was a big thing several years ago, and a lot of people still say this, that without follow-up, a lot of the work you're going to do is not going to have effect. And I was involved in different programs that didn't have much follow-up, but I saw some things and I thought, well, hang on, these kids are actually using this experience as a new benchmark for what they're going to accept in life, and that everything will be better than that. And one of the things that really got my attention is a program I was involved in. I know of, I think, 3 young people who tattooed the logo or the name of that program onto their body. You can't tell me that that's not going to have a significant effect on that young person, probably for the rest of their life, unless they get it tattooed over. So I think they're finding ways of pursuing the experience that they had and keeping it alive for themselves so that they can use it to help them solve the problems of the future. So I think if we think about what happens after the program, which after all, that's what we're here for. We're here for healing, and we're healing for improving people for the long term, not just giving them a holiday, although the holiday is good. So if we take some ownership of how they might continue this wonderful journey afterwards when they're not in our presence, and how we can help them to figure out how to continue applying the lessons but learning more, then I think we're doing the right thing. So this is my construct of the clinical literature's phased approach. The last thing I want to say about it is that this is way too linear. It's very difficult to put it on a page and display it as a diagram. I think we're looking at spirals. We're looking at feedback and feed forward loops. It's not a straight line. You can get phase 1 safety being an issue at any time that you're working with a young person. So the phase is really about where do they sit in that. Remember that model, we had the triangle with the brain as a guide. Where do they sit on that? How well brought together are these young people? How able are they to connect to the experience? And that's really what we're talking about in phase, rather than the phase 1 is the first 3 days, phase 2 is the next week, phase 3A is the last 2 days. I think there is some truth in that from a program design point of view. But I think in terms of a practitioner young person relationship, I think we could be at any of those phases at any time, and they can skip across from one phase to another without necessarily going to the phase that's in between. I think we need to think about how well is appropriate is this phase for this young person now, and how do I help them if that's where they're thinking. So I've had kids turn up on day 1 of program, they're thinking about returning home. So they're already putting themselves in 3B. We haven't had the experience yet. So I'm thinking, how do I help them to have that experience so that they can have a richer conversation about that, but they actually want to talk about it now. So that's what we're going to do on day 1. So yeah, that's my only criticism of your otherwise lovely looking PowerPoint slide, Will.
Thank you. Absolutely. So you need to make us a new more circular chart.
Yep.
Yeah, exactly.
I'm thinking more Rubik's Cube at this stage, because the diagram, 2-dimension doesn't do it for me.
Yeah, good point. I'd like to I know we're going to go through some of these phases, but I'd like to think about the processing new and positive experiences. In a lot of the outdoor adventure education literature, we look at, if you go online, you can get the Walsh and Gollin's Outward Bound model. You can get that article for you as well. I can send it to you all who have registered as well. But we've been talking for 50 years about how experiences of success and mastery can help somebody improve their well-being, whatever outcome we want to call it. What that means is we don't look at going outside as let's go make this person really uncomfortable, push them out of their comfort zone, and then they'll come back reorganized and be a stronger, they'll have better self-concept and locus of control. Because first off, we really relate to Denise Mitten's work, really sort of reimagining the construct of comfort zone. That the idea that we should make people uncomfortable sort of comes with the assumption that people are comfortable to begin with, and that we should do something to make somebody uncomfortable. We don't really look at it like that at all. What we're really thinking is providing experiences for people where success and mastery isn't only possible, that's all we can, that's all we really want to make that happen. And then when we process it, our questions are really related to how that person was able to do that experience so that they can create some meaning attached to that positive experience. And I think after what Graham said, every participant who comes on my program is probably going to have to get tattoos at the end of it. We'll just put that into our practice framework. But what I've done is I've just pulled out a bunch of ideas that we've talked about in the paper for these phases. So this is not an exhaustive list, but if there's anything else that you all think about that you can add to what we can do to help our participants feel safe, I'd love to see it in the chat box as well, and we'll have time for some discussion as well. One of the big ones that really changed my programming is being trained in the United States. Many of the programs I worked on said, don't provide your participants with future information. The idea of that is to help them stay in the moment. But how can someone feel a sense of control if the entire program is unpredictable because we haven't provided them with future information? So if anything, the setting we create should be very predictable as well. So that was an interesting for me to get out of the way I was trained as a young practitioner to really start thinking about how can I really help create a sense of safety.
Yeah, and Will, you're not that experience of no future information. I saw, didn't get involved in it myself, but I know of an organization that morphed into another one. And they had all of the clocks that they couldn't actually remove were set on different times so that young people didn't actually know what the time was. So that they had to buy into what's happening now. And you think, well, I understand that. And there is some, I can see why you do that, but also that's, you know, particularly our kids who are now very much onto their devices. I wonder is that just going to be dysregulating? Because maybe they're thinking they really just want to know, how long is it until dinner? Like, when can I eat? When can I expect food to come along? And if you've changed all the clocks around and they're losing track of time, I don't know what that does. So I don't think it's not just a wilderness therapy thing in the States. I think it's something we do elsewhere, in other places. But I wonder whether some of that comes because the wilderness therapy literature out of one research center is so extensive and the volume is so much that it gets interpreted by people around the place who are doing the similar thing. So again, trying to go back to first principles and human rights as an approach may help us think about the detail of what we're reading. Does this actually help me achieve what I'm trying to do when helping this young person? Because the literature and our knowledge is changing so quickly that just taking a research paper, even this chapter of ours, is going to be dated. Give it a couple of years, and people should be looking at this through a totally different lens and thinking, well, is that correct or not? And we'll have to do a second edition.
Yeah, and one of the other things I really took away from one of the intensive trainings I did with Graham was really taking it slow at the start. You know, we're forming a group. So these young people are not only potentially meeting new people for the first time, They're rolling a sleeping bag, using a stuff sack, using a backpack, maybe breaking in new boots. And so a lot of programs I've witnessed and I've run, we start with an information overload. And so we like to take it a bit slower and avoid really long, very long, drawn out explanations of things. And a question in the chat box, absolutely encouraging them to participate, that their voice matters. One of the things when sometimes we position the folks who come on our programs as the recipient of our expertise, we really want to view them as active participants, that they are the wild card of what comes into the experience. I like the term revenge of the clients. I want them to really feel that they are, they really matter, they count, they're a part of this group all the way. They don't just have to follow the Will Dobod regiment as well. So phase 2, and absolutely, Oliver, great idea to have them help plan their experience as well. I know I brought I got some funding a few years ago running a program in down in Victor Harbor at the alternative school down there. And so clientele with pretty serious disadvantage going on. And we brought maps, pictures, activities, and we put together the whole thing along with their parents as well to do that. So phase 2, we sort of touched on this. What other ideas do we think about when it comes to processing the what goes on in an outdoor therapy experience? Is there anything that comes to mind for you, Graham?
Yeah. So the heading of that particular phrase, I've used the words fairly carefully. So certainly we can, I think processing experience and understanding all the different layers of what happened is important. So we're talking about processing the experience we're having now, but I think the experience is the most important part, because otherwise you've got nothing to process. So I sort of explained to my staff that you spend 16 hours a day so that you can have 40 minutes around the fire. And it's the 40 minutes that is the processing. It's the experience is the 16 hours or whatever it takes. And so we really got to work on living the dream, I guess, for that the bulk of the day. And then the formal processing will be like the sitting around the fire or like the circle at the end of the day if we're not staying overnight, those things. So that's that part of it in terms of working with a group, that the processing is really, really important, but only if you've got the experience. But you can't really, it's the other way around as well. But also during the day, there's all these micro moments where something happens for a young person and they'll have a little bit of that happened. There'll be a small conversation about that, or you'll just see the look of, something just happened there. That felt good. And you may not want to talk about it. You might want to just respond with a gesture or with a pat on the shoulder or a smile. That's an element of processing as well as a communication between two people about what just happened. So it's not always, you've got to be present to the experience of the young person throughout the day and helping them get what they can out of every moment. It won't always involve me as, if I'm running it, it may involve the other people I'm working with or young people themselves, but we're looking to create those different opportunities or to reflect on those different opportunities for what the experience has taught them. It's something that the literature told me, which I hadn't really been thinking about when I was previously, was the idea of mentalizing. And my understanding of that is that you and I can both have an experience, but we'll have a different interpretation of what happened. And so often I've seen sitting at the end of the day, talking about what happened during the day, people going, when that happened, I thought it was because of this, and I thought you were angry. I didn't realize that this happened and that was not how you were feeling. And so if we want people to have empathy for others and to understand others, first of all, we've got to have them to understand that our experience of the same thing is not the same. And so if we go straight to trying to build empathy and how do you think he feels about that, that's something we do towards the end of phase 2, perhaps, because maybe they don't even understand that we haven't had an identical experience of the day. So again, it's not as if there's early phase 2, there's late phase 2, and you do things differently as the days tick by. Sorry, I think that waffled on a bit.
No, I think that's okay. And there's a question in here for you, Graham. Can you give an example of how to raise developmental response to triggers?
Yeah. So if a young person is having, and I'm thinking more of my foster care work, but I've seen this on program as well, that a young person first something might happen and they have what looks like a 2-year-old temper tantrum or 3-year-old temper tantrum, whatever that is, and they're just going to town over things. If later on they've learned that, well, this is how it works and this is how I can, people will help me and I don't have to necessarily be quite so demonstrative over something going wrong, then maybe they find that they can later say something, oh, this didn't, I'm really unhappy with this. That's developmentally a higher level of protest, I guess. So I'm talking about those sorts of things. I ran some abseil, or if the Americans are here, a repelling, a couple of months ago. We had a young woman come in who wanted to do the abseil, and she was really, really freaked out about it. And she told me that she needed to stop, at which point, absolutely, we stopped. But she was barely able to articulate anything. The words wouldn't come out. She wasn't in tears, but as soon as I got her to safety, she collapsed into tears and she was crying. So I sort of explained what was going, how I understood what was going on for her, etc. So we had a little bit of a conversation. She came back 5 times on that day. And the very last time she did the abseil, she got to exactly the same point she did on the other 4 occasions. But she looked at me and she said, "Thank you, Graham. I'm not abseiling any further." And that was the end of it. So developmentally, that's one way of looking at it, that she had learned through my response to her distress that she could articulate herself in a way that is much more cognitive, much more adult-like. So that's the kind of thing I'm talking about. There's a much developmentally raising the response to triggers. There's triggers everywhere, and we want young people to be more functional in the face of a trigger over time by having lots of experiences to build them up through those levels. Yeah.
And I think with the level of experience, I know just from some of the people in this meeting today, there are probably a billion ideas of how to help the transfer of learning from what happens when we're out bush or outside and making that relatable to home. So if there's any other ideas of doing that, I'd love to hear them or see them in the chat group. But it's really important that we prepare the groups that we're working with outside, that they might be leaving each other, might not see each other again. And so we spend a lot of time preparing for that to happen. Graham, do you have other ideas of what you're kind of thinking about here?
I know, I've seen a lot of young people. They know how to leave a relationship. They're very experienced in relationships ending. They're not often they're not very experienced in relationships being maintained or being able to separate and end a relationship without it being a big drama and a big the relationship ending because you're angry with each other. So I've seen young people who've had a great time, really formed a real bond with other people without me sort of doing anything to help them to work out how to deal with grief. The last thing that relationship experienced was one person swearing at the other one, because that's how they knew, I suspect that's how they knew how to separate. So I've now become I now start in a few days before the end of the program, I start talking about what are we going to feel? How will that manifest in your body? What sort of, how, these people are, you know what they're like. So if they act differently in the last couple of days, maybe we interpret that as they're feeling really sort of awful and they're not, it's not a good feeling to be separating. So maybe a little bit of they haven't changed. They're just trying to deal with something and may not know how, and then teaching people actually how to say goodbye. So this is the goodbye ritual. This is how it works. So they've actually got a model to go by, and they can leave at the end of the program and not having violated one of these relationships. Often they value extraordinarily.
Yeah, great point. Definitely, it can cause anxiety. And after a program, when young people return to their community, their sort of life as usual, we definitely want to create a lot of artifacts that can remind the participant of their positive and new experience. So lots of photos, videos of the programs as well. And sometimes we can do some letter writing. I was, about the experience, all those sort of things. One program we did, we invited one participant to write a reflection about the day for each day of the expedition. So then they got a book journal with everyone's different reflections in there with pictures and everything. So they can always go back and look at the positive experience. One of the things, I am shamelessly a solution-focused worker. And even in my PhD, I tried to not write a solution-focused PhD, and I did anyway. But one of the things I like to think about with outdoor therapies, and Katie asked if we can do this in shorter sessions than having the luxury of going away for a month-long trek. Absolutely. I think a lot of these guidelines are similar. One of the things I'm looking at is I really want the expedition to be an exception to the problem that got them there in the first place. So I want that experience to be drastically different so that there's something very positive to process. They were able to stay regulated when it was raining, and when they typically get frustrated before. They were able to build good relationships with adults as well when maybe that hasn't happened in school or in when they're in care. So I want that to be, I want the experience outdoors to be drastically different to the problem that brought them there. And what we know, and 100 years of psychotherapy research has all but reinforced, we don't really need to know what the problem is. We don't, asking questions and getting a bunch of information about the problem, all that sort of does is give us more information about the problem. It doesn't necessarily lead us towards a solution. So we want a lot of the positive experiences. We want to help that to integrate at home, and follow-up is great. I created a program in the United States called Potomac Pathways with my biggest mentor, Brooke Brody, because we saw a lot of people leaving wilderness therapy. They would be referred to ongoing therapy, but they were referred on to people who have no idea what it's like to bow drill a fire, or what it's like to live outside for 60 days. So we wanted to create aftercare with outdoor therapy folks who knew what that's like in that experience. And so, yeah, sometimes just going, well, they've had the expedition, let's send them to the psychologist now. That might be that might not be the best idea, because that psychologist might have no idea what it's like to be out there. So having people that have an idea, that have had those positive new experiences, can be really good.
I've got a couple of things that are happening in the chat there, Will, I might address as we're going. First of all, I just want to acknowledge that Russell Chamberlain before said it's really important that young people learn to be able to say no, and in my words, no and retain their dignity. So he's referring to phase 1 and 2, I guess. But at any time, the catchphrase that I'm referring to here is that no means no. So if a young person says no, that is it, absolutely. That needs to be not thought, or how do I convince you to do the thing that I really want you to do? The kid said no, stop, end of story. We then deal with, why did they say no? Is there something that I need to change about my practice so that you're feeling safe and comfortable with me to do the things that you want to do? So I like the repelling abseil scenario because it's a really good opportunity to you can identify a moment where it's going to be stressful. And if the young person can, to whatever level, engage with that and feel that they still have retained their dignity, and they perhaps said straight up, no, I'm not going to do it, or if they got to a certain point and said, no, stop. If they feel powerful and dignified in that experience, then we've done the right thing for them, in my view. So there's just about that activity. So someone has also asked about, what about return sessions? Can that work? So one of Denise Mitten's articles was about 2 hours of bushwalking, walking in the woods, or whatever you call it, had a measurable effect. 2 hours once a week had a measurable effect. A lot of the work that we do on the photos that are down the side of the slides, the young people come to us for 3 hours once a week. And they might do months of this and come and see us weekly. And the same model is applied, knowing that we can be in any of the phases on any given session, but we can predict fairly well how it's going to go. It's going to follow roughly the session process, the phase process, but we may jump backwards and forwards because they might have a really bad day at school. Suddenly you think you're in phase 3A, but you're actually in phase 1, and cope with that. The last one, somebody was asking about how do we link to talk therapy, and what do we do about not going back into that past history? That is really important work, particularly when that's having a dissociative effect on people. And so for me, as an adventure-based youth worker rather than as a clinician, there's two things. I referred earlier to, are we providing this experience so that we can mentally leave the experience and start talking about something else that happened years ago or 3 weeks ago? Is that what we're here to do? Or should we stay with the experience? And I'm not saying it's an either or, but I'm inclined to stay with the experience. That's where my skills are. But in 3A and 3B, we're wanting them to, if it's going to be helpful for them, to engage with the therapeutic process more. And hopefully they can figure out with their experience how they can engage in a top-down structure, because they can facilitate bottom-up for themselves. They've hopefully learned how to do that. And so then we're linking them in the last few days of program. We're saying, well, what do you want to do in your healing journey? What sort of person might be able to help you with that if you need one? And how do you engage with those people? So we might be, what that might actually look like, we're saying, oh, I know this person who does this wicked art therapy stuff. You're right into that. Do you want me to link you up with that person so that when you get back, here's a referral? Or you want to talk about some of these things which are eating away at you. You need a good trauma lens of talk therapist. Well, I know these people. Do you want me to refer to give you their card so that you can make contact? That's the sort of stuff we're doing. So I very much after the experience, the top down may need to happen for a lot of people with those significant events, or those grinding kind of events, experiences where they're in a family that had a particular way of doing something. And learning how to live their life, but not that way, could take quite a while of working that out. And it might be that they need to go to a spiritual advisor as opposed to a talk therapist. So yeah, all those things is what we're doing in 3A and 3B.
Yeah, absolutely. I just wanted to, 1 second. Really, thank you all for coming. I know we've just gone a minute over. But I mean, 110 people in this room, some I know, some I don't know. I hope you all stay in touch as well. I've created the Facebook event group for that, so you can find that by doing a search for social sciences and outdoor therapy, something along those lines. But definitely, I'd love to keep the conversation going. If there's any, I'm happy to stick around for 5 or so minutes before I've got to get ready for my next meeting. How I'm going to grade the billions of papers I should grade today, I don't know. But if there's any questions, comments, thoughts, I'd love to hear it. And yes, we'll email the slides to everybody as well. I'll put it up in that Facebook event if you'd like to join. That if you're not a social media person, which I understand, flick me an email as well. But yes, I hope that was interesting as far as a brief crash course into how we can take this complex trauma literature and implement it into our programs. And absolutely.
And I generally tell, because we deal with a range of people who are involved with adventure therapy of different types, give it a crack, give it a go. Follow Fallett and Harris's 5 principles, follow the phased approach, give it a shot, because if you stuff it up, then it's an excellent opportunity to say to the young person, hey, I think I've just done the wrong thing. How can I make this better? Because that was my mistake. And guide me here, tell me how I can improve my practice. How can I restore this relationship that I've just tried to do something good for and failed miserably? So because it's strength-based and we're not trying to do the exposure stuff in my practice, it's I think it makes it easier for us to have a go and follow our intuition a little bit, based on a human rights perspective. I think that's where your intuition can get you ahead of the game.
Absolutely. I've put my email there. Anybody can email if they'd like to, and I can send those resources, but I'll also make sure that we get them to you as well. Thanks so much for coming along. I hope for those who it's Monday, I hope we didn't add to your case of the Mondays. For those who it's in the evening, definitely we hope you have a great night. For anyone else in another time zone, I hope you take care. Graham's put his email in there as well. Hey, Alan, great to have you. And the one final thing I was going to say is yet tomorrow, the series continues with a chat with Nevin Harper in Canada, and we'll talk about sort of our review and overview of outdoor therapies in our text. And if you want to, just while we're here, for Social Sciences Week, all of these books are, you can get 30% off plus free shipping with the Outdoor Therapies book I edited with Nevin, or the Nature and Health book, which has the chapter Nevin and I were referring to, if you'd like to. But besides that, thanks so much. And I hope you all have a wonderful day.
Thank you. Bye, everybody.